All right. Well, thank you all for joining our COVID-19 Preparedness Echo Lecture Series. This is the first session, and tonight we'll be hearing from Dr. Bridget Hurry, who will be giving an overview of the disease, proper diagnosis, infection prevention, and proper PPE use. And then we're going to hear from Jose Laguna, an ICU nurse in Spain, and he's just going to be giving us a quick little overview of what he experienced working in the ICU with COVID-19 patients. After that, we will open it up for question and answers. If you have any questions, feel free to type them in the chat box, and we will also be opening it up for other questions as well. Monica?
Hi everyone, Monica Kainer here from Assist International. Thank you so much for joining us today. I just wanted to thank a few organizations for allowing this to happen, including the GE Foundation and David Barish in particular, Project Echo headquarters, who made all this possible through their platform, the Tanzanian Ministry of Health, who we work with very closely on our Safe Surgery 2020 Echo program, as well as many other partners that are here on the call today. We hope to continue this lecture series with you on an ongoing weekly basis. I'm now going to turn it over to Vaughn Williams from our team to start the presentation.
Hi everyone, I'm Vaughn. I just want to go over a few etiquette points before we start. To begin with, ECHO is kind of founded on an idea of love and respect. So we ask that when you disagree, you do so kindly. We want to maintain an atmosphere of collaboration, and we see that it's everyone's responsibility to keep ECHO a safe space for learning. We also ask that you test your equipment ahead of time to make sure your audio and video is working. And then at the end, during the question and answer session, there is a raise hand function. If you go to the bottom of the screen, you'll see a button that says participants. If you click on that, you'll see a list appear on the right hand side of your screen with a button that says raised hand. If you click that, you can then ask a question. We ask you to introduce yourself before you speak. And just be mindful of what you're doing when you're on screen. Signaling can be distracting. Avoid making any loud noises. And in general, just keep your microphone on mute when you're not speaking. The mute button can be found in the left bottom corner of your screen. But then remember to unmute before you start speaking. Try and position your webcam to effectively show your face with good lighting, and try to avoid being lit from the back. Try and speak close to the microphone so everyone can hear you. And should you have any IT issues, you can send us a message through the chat at the bottom right-hand screen or through email. And that's it. So now Bridget is going to start the presentation.
Yes, and Bridget, you should be able to share your screen now.
Wonderful, thank you. I'm gonna.
And just while Bridget gets herself ready, Monica here again, a reminder, if you have questions for our Q&A session after the two presentations, we'll spend a lot of time on questions. So please send them in the chat function at the bottom in the chat box. Message them to us and we'll make sure to address them after. Or please raise your hand. You can see that on the bottom right of the participants section. And we'll make sure to try to get to as many people as possible. And someone just asked how we can get copies of the slides. We will have them available after the sessions today. Within the next few days, every week we'll have the slides available afterwards. They will be on our website at assistinternational.com, and we will let everyone know how to access them. We'll send an email after the session. Thank you. Bridget, over to you.
Good morning, and thank you so much. My name is Dr. Bridget Hurry. I am an obstetrician gynecologist who is trained in the United States, and I spent 6 years living and working in Uganda, Africa. So, Jambo, Rafiki, Habari Yako to all my Eastern African colleagues. I will be sharing today, as my Assist International colleagues have shared, a brief overview of COVID-19, as well as reviewing diagnosis, infection prevention, and proper PPE use. Then my colleague Jose will be able to share from his lessons learned there in Spain. At the conclusion of our presentations, we will have a dedicated time for questions and answers. So please, if you're able, save your time, questions for that time, and we will make ourselves very available. For today's presentation, we'll start with a general overview of COVID-19. It's a large positive strand RNA virus that was first discovered after a cluster of patients were identified with disease in Wuhan, China. The initial viral name was given COVID-19, with the disease process resulting from this virus being called SARS-CoV-2. The disease process has been shown to have various clinical manifestations, with the chief manifestation being mild in the majority of patients. Mild illness has overall looked like a chief clinical complaint of fever, dry cough, and or shortness of breath. Some patients have complained of sore throat or myalgias or other symptoms such as unexplained loss of taste or smell. For severe cases, which is about 14% of the cases, the chief complaint is a pneumonia requiring hospitalization. Critical cases have been seen in about 5% of our COVID-19 positive patients, and that involves respiratory failure or septic shock. We know that the incubation period is looking to be on a median of 5 days. The median age of disease onset is in the late 40s, around 47, with more men being susceptible to this illness and this viral acquisition than women. And currently, we know that there is a transmission susceptibility through droplet transmission, contact transmission, as well as airborne transmission. Droplets are respiratory specimens that can transmit through the air within a 2-meter radius or 6 feet. Contact transmission is from a contaminated surface, and it's thought that they can be infected for up to 6 to 9 days without disinfection. An airborne transmission is currently under investigation, but thought to be possible with our 1% of patients carrying asymptomatic disease, and yet transmission still being possible. We know that In some patients, there have been a high level of viral load in the nasopharyngeal samples. So that is suspecting that there's infectious potential before symptoms. We're unsure at this time the duration of shedding of the upper and lower respiratory tract virus. The viral loads are thought to be higher earlier in the disease process. For patients who've been hospitalized with pneumonia, we've seen these most common laboratory findings of lymphocytopenia, thrombocytopenia, and leukopenia. And then for radiographic imaging, on a chest CT, we have seen ground glass opacities as well as multiple areas of consolidation. We know that on X-ray, the imaging seems to illustrate bilateral peripheral distribution with an increased involvement in the lower lobes. For diagnosis of COVID-19, especially in a resource-limited region, the key for the diagnosis of this disease is the screening of all patients at their initial contact with any healthcare system. For any patient presenting, we must immediately ask every patient about any symptoms consistent with COVID-19 infection, such as fever, cough, or shortness of breath. We must ask every patient about close contact with any known or suspected case of COVID infection. And we must ask every patient about any travel to any area known to have local transmission of COVID-19 disease. If possible, the recommendation is to have a temperature measurement on every patient as well. For any positively screened patient, the recommendation is to give them a mask immediately and to try and isolate the positively screened patient at least 2 meters from other persons. And all healthcare personnel should wear positive protective equipment, PPE, when evaluating a positively screened patient. This slide just illustrates 2 key points. One is that for mild, moderate, severe, and critical disease, the recommendations varies, but self-isolation, such as home restriction, is a key component for the management of the majority of our patients. I'll refer to this more as we carry on. These patients should have access to healthcare through telephone, e-health, or a local healthcare facility, but the majority of our patients can be treated with supportive care from home. The other point from this slide I'd like you to notice near the bottom is that there are known comorbidities for patients that could be at risk for developing severe or critical COVID disease, and that those comorbidities include advanced age, cardiovascular disease such as hypertension, chronic respiratory illness, diabetes, cancer, HIV, or other immunocompromising conditions. To diagnose COVID-19, the CDC is recommending nasopharyngeal and oral pharyngeal swabbing. These swabs are sent for a reverse transcription polymerase chain reaction, or PCR assay. The WHO recognizes that there are not reference laboratories in all regions currently. And by getting access to the WHO website, you can find reference laboratories for your region. And it is important to follow the special instructions and documentation on their website for the shipping of your respiratory specimens. For the personnel collecting the nasopharyngeal specimens, you want to ask your patient in question to blow their nose. Then they may tilt their head back slightly, making the nasal passage more accessible. Inviting the patients to close their eyes can alleviate some discomfort. And then the examiner inserts the swab just along the nasal septum above the nasal floor until resistance is met. The swab is then rotated for 10 to 15 seconds and then placed into the container and capped to be sent to the laboratory. The key at this point in our COVID-19 pandemic is as a collaboration of personnel to join together for infection prevention measures. The key to this for all involved starts with hand hygiene. The recommendation is to keep a 2 meter or 6 foot distance from one another. This involves no participation in crowded events. The recommendation is to avoid touching your own face, including eyes, nose, or mouth. As previously spoken of, the recommendation is to continue to disinfect any frequently touched surfaces for decreased contact transmission. For washing your hands, if there is no visible contamination or soiling, you should use a 60% or higher level of alcohol-based hand sanitizer and rub the surfaces of the front and back of both hands for a minimum of 20 seconds. If there is visible soiling on your hands, the recommendation is to use soap and water, washing all surfaces of both hands for a minimum of 40 seconds. For any cough or sneeze, the recommendation is to cover your mouth with either a bent elbow or tissue. And if you have respiratory symptoms, it is imperative that we ask that patient or yourself to wear a medical face mask. For healthcare personnel interacting with COVID-19 infected patients or suspected infected patients, the recommendation is to wear personal protective equipment, PPE. This entails an isolation gown, a respirator or face mask with the N95 filtering face mask being the highest recommended respirator, a face shield or goggles where eyeglasses are not the standard due to side exposure, and so face shield or goggles even over someone's prescription glasses is recommended. And lastly, gloves. This slide just indicates there are different PPE needs according to the role of your particular healthcare provider. Notice for our cleaners, we want them to be wearing heavy-duty gloves and boots or closed work shoes, as there could be the risk of contamination from splash in their line of cleaning. Lab technicians must be careful as well of a risk of splash, and other recommendations for temporary isolation are listed here. A minimum of 1 meter is noted for isolation purposes, but not those involved in direct patient assistance. 2 meters is the recommendation for any patient care, any COVID-19 presumed or positive patient. To put on or don one's personal protective equipment or PPE, it is important that you first gather all the required gear outside of the patient room. If patients are cohorted in a general ward, this should be done outside of that general ward. You first perform hand hygiene, again, 20 seconds of minimum of a hand rub with a 60% or higher alcohol hand rub. You then apply your isolation gown with all ties being fastened. Some may need to have the assistance of a second healthcare personnel. You then would put on your face mask with 1 strap above the crown of your head and the second strap at the back of your neck. For face masks with loops, these adhere around your ears. You would then apply your goggles or face shield. Lastly, you would perform 20 seconds of a hand rub with 60% or higher alcohol hand rub before putting on your non-sterile gloves, and they should cover the cuff of your isolation gown. For the removal or doffing of your PPE, this should occur within the patient room, but near the exit. For a cohort of patients, this would be at the exit from the COVID-19 isolation unit or ward, and preferably there would be a waste container at this exit point. You would first remove and dispose of your non-sterile gloves. Currently, there's a difficulty in recycling gloves, so this is largely being disposed of. Then, still within the patient room, you will remove your gown by pulling or rolling down from your shoulders and away from your body. The reuse of gowns has been noted. Often they can be saved outside a specific patient or cohort area to be donned in that particular COVID-19 clinical scenario alone, but you must roll the contaminated or outside surface of these gowns upon itself so as to not contaminate your bare hands. You may now exit the patient room and perform 20 seconds of a hand rub for hand hygiene. You will then remove your face shield or goggles by pulling away on the straps up and away from your head, being mindful to not touch the front of your face shield or goggles. In a similar fashion, you will remove your face mask by grabbing the straps carefully and pulling up and over your head. It is imperative to avoid touching the front of your face mask or respirator, as that is where contaminated respiratory secretions can be found. And lastly, you'll perform your hand hygiene. I have a video here that can illustrate our donning and doffing opportunity, but due to time, we'll provide a link for this. It is on YouTube. It is also important that we continue as healthcare providers to optimize the availability of our resources. We can use physical barriers such as glass or plastic windows when patients first access a healthcare facility in order to decrease transmission. We need to restrict healthcare workers that are entering rooms if they are not involved in direct care of the patient, so as to not use PPE wastefully. There's also recommendation to cancel all non-urgent procedures in an effort to save that supply of PPE gear. And we need to be careful in restricting the number of visitors for patients to, again, optimize our PPE availability. There are interested areas of PPE decontamination efforts. Currently, the 3 modes of decontamination being investigated use ultraviolet light, moist heat, or hydrogen peroxide vapor. The majority of this decontamination effort has been focused on the N95 respirator masks. In the case of a positive COVID-19 incident, it's important to access the World Health Organization's website, which contains a case reporting form that can be filled out and submitted within 48 hours. Thank you for your attention, and I'd like to now turn this over to my partner, Jose Laguna.
Hi, everybody. And before Jose starts, if we could just remind everybody to keep themselves muted until they're asking a question and to save all questions until the end. If you have a question that you are afraid you'll forget, please type it in the chat function.
Okay, well, hello to everybody. My name is Jose Laguna. I'm an ICU nurse. And since some years ago, I work as clinical specialist for Masimo Corporation. It's a monitoring company, now focused especially in ICU settings. I've also worked a couple of times as a volunteer in Africa, so I just know a little of the weakness of the healthcare system in some countries. So in Masimo, I'm specialist in ICU monitoring, and now with this pandemia, what I'm focusing is on training people how to adequate sedate patients with different drugs, because the problem we're having now in the ICUs is that the usual drugs that we were using are running out. So we're starting to use drugs like ketamine or dazolam that people are not used to it. So it's getting very tricky. So that's my main job now in Masimo. And as for now, what I did is I went back to work as an ICU nurse in Madrid. We have this big explosion of cases, so there was a lack of nurses, ICU nurses. So I volunteered to go there. I'm working now in a big hospital in Madrid, in a COVID ICU that was done for this. So I work full time in the hospital and keep some of my duties as clinical specialist for Masimo. So In Spain, what do statistics tell us? So in Spain, we have around 140,000 infected people. It's much more because we are one of the countries that has least tests per million people. So it should be much higher than that. But of those 140,000 positive, 20,000 are healthcare workers. That's 14% of total infected population. And that's critical for us. That really made a big problem here. Hospitals in Madrid have duplicated their ICU beds. And an average of 95% of ICU patients are intubated. I mean, in normal situation, we will take them to the ICU before having to be intubated, even before. Now we just wait until the last moment because there are no beds in the ICU, even if we duplicated the sizes of the ICU. So we have an average of between 90 and 120 intubated patients per hospital, and patients that are incredibly unstable. So healthcare staff that work in direct contact in these COVID units, I mean, we're not thinking if we will be infected, but when we will be infected. And we are all hoping to fall sick after this chaos finishes, but not in the middle of it, for the sake of patients, for us and our families. So it's not the best moment to have a lot of staff workers sick or ill. And we have a lot now in Spain, because we did many errors, many mistakes that I'll talk to them a little bit later about what could have we done better. So going back to our main topic, what mistakes did we make? Well, first of all, we did not believe that this would happen to us. So we just waited until everything exploded and then it's too late. So we were also thinking that we have a very robust healthcare system that did not prepare extra staff, we did not prepare for that was coming. We did not test early patients to detect, like in Korea, who was infected, to isolate them quickly. And we took preventive measures very late for that. Also, we were thinking that this only affects old people. Everybody's telling us, oh, well, it's only going to affect you if you are more than 60 years old. Well, no. I mean, more than 60-year-olds is going to be even worse. Yes, of course. But it's not only above 60 years old. So the younger people were just not worrying about it and not taking enough measures to protect themselves. So we should be cautious and take measures before the blast arrives, because when chaos arrives, everything gets much more complicated. Changes are much more difficult to make, more difficult to implement changes. There is a lack of adequate protection materials. You don't have enough stock of drugs, so how are you going to sedate patients? How are you going to reanimate patients, resuscitate patients? We don't have enough staff because we have much more patients than before. They are more critical than before, and we have a relatively high number of the staff that is at home in quarantine or sick. Also, remaining doctors and nurses start working in areas that are not the specialty. We had pediatrician intensivists that are working with adults. We had dermatologists in the emergency care room. So people are just trying to help as they can, but they don't know their job, so that makes it dangerous. And there was in the beginning a lack of protocols to follow. It's like everybody was doing their medicine. We used the system of trial and error. And training was done when people like me jumped in to help, was done in a hurry with live cases. So when you make a mistake, that's a bad mistake, because patient can suffer that, or you can suffer that. All this training should have been done in advance. So how did this start in Spain? Well, we started seeing just a very little cases in Spain. So start 2 or 3 patients in the hospital. Next day it doubled. Next day triple. And before the week changed, before the week passed, it was getting completely out of control. So the first 2 weeks were critical regarding hospital staff infection because there was no adequate protocol. We thought it was going to go little by little, but no. In 4 or 5 days, it went from 2 patients to hundreds. And then that was really complicated to contain. So there was not enough protection material for the staff, or the staff didn't know how to use it properly. They didn't know how to clean everything correctly. There was no real good protocols there. So then 1 week after the emergency room got crowded and overloaded, then we are starting to see the critical patients. After 10 days, 14 days being infected, it was just an exponential raise. So what happened is we have the ICUs collapse. So we had to cancel all the surgeries, just remain with the urgent surgeries because there was no ICU beds available. The first healthcare staff started to show symptoms and put in quarantine. So then you got a fourth of the hospital staff in quarantine. Emergency units started to overload. We had a waiting list of between 100 and 200 patients to be admitted in the hospital each day. Critical patients continue to increase, so we just have to make ICUs where there was no ICU. So we did ICUs in recovery rooms with the anesthesia machines. We asked for ventilators and put wards. We put there a lot of ventilators, monitors, and tried to make ICUs there. And we did ICU. That's why we duplicated the size. So the problem also we had now was the staff. Okay, so we have a lot of ICU beds, but you have a lot of staff that is sick, and you have double the patient, the type of critical patients. So you need double the staff, and you have less staff. So that was also a big issue for us. So we called also last year medicine students and nursing students to come here and work. And for example, in Madrid, they did a great call to ask people to jump in and help. So that's when I jumped in and helped customers. And that's when we really realized that we are in a very, very bad situation. So there's a problem that there was a lot of physical treatment in the patient, a lot of treating the ventilator, in contact with the patient. There's a lot of proning or changing body position of the patient from face down to face up. And that's a very complicated maneuver because you're in contact with the patient, you're face to face with him, with a COVID patient. And in the beginning, it was done with insufficient protection material and with lack of proper training, which made it much more difficult and dangerous. People should have been trained in this earlier. Because sometimes they just came to, well, most of them, as they jump in the ICU, they get intubated and they put in prone position. So one of another mistake is that each unit, like in a hospital, we have 5 different ICUs. Each unit had different treatment protocol. So you went from one to another, you didn't know what the protocol is, what the drugs were, what that was, and it was not practical. So something that we changed drastically in the hospital, say, okay, let's make it simple. Let's just not let people think. We tell you what to do. You do A, B, C. Treatment, the same for everybody. Same sedation protocol, antibiotics, hemodynamics, ventilation criteria, with some, of course, exceptions, but try to follow everything the same. The time where the drugs are made is all at the same time, so you don't have to enter many times in contact with the patient. So we have a list everywhere in the hospital of the different drugs and dilutions to avoid accidents, because less than half of the nurses did not work ever in ICU, or like me, I've been 10 years without working in ICU. So you're slower than usual. Also, we have some doctors, some specialties like surgeons that they wanted to help, but their specialty was not really practical in this situation. So what they did is they did a proning team. So when you have to change side of the patient, move a patient, there are this group of 4 or 5 surgeons that come in well equipped and perfectly trained, and in a couple of minutes they're able to wash the patient, turn the patient upside down, and take care of the ventilation situation of that patient. And they really do it very well. And that has helped a lot the ICU staff in this matter. So also something that the region of Madrid has done is they have opened free hotels and recruited staff from all over the countries. So they have put free transport for healthcare workers. They put hotels, transport from the hotel to the hospital. They just made it simple so everybody that wants to jump in can help easily. So the first day I started working in the ICU, what shocked me most was that 90% of the patients had between 35 and 55 years old. They were not the people I heard were most affected. All of them intubated, all of them in a critical situation. So why was this? Why was this? Because most of the older people die at home or in retirement homes. I mean, they don't necessarily get to the ICU. Some of them, I mean, this COVID, what we are seeing is that there's an inflection point in a certain moment that goes from 0 to 100 in a few hours, sometimes minutes. So some people just don't have time to get assistance. And also, we have an extreme lack of ICU beds. So when a doctor has to choose, he has 2 ICU-free beds, and he has 10 patients for the ICU to intubate. Unfortunately, they have to choose who to intubate. And they choose the one that has more possibilities of survival, which is the youngest one. So when I entered the ICU, the threshold was 60 years old. Above, we did not intubate. That's why we had only young people in the ICU. Now we're getting better, if we can say that, because we intubate between 65 and 70-year-old, not up to 70, but almost. Emergency rooms are getting better, but in the ICU is still really complicated. So now that in Spain we saw this situation, we started to have strict, severe self-isolation measures for the population. So now nobody can go out to the streets just to buy the basic needs that you need. You can see everyone that goes out with gloves and with masks. We have opened hospitals in Congress halls because our goal now is to try to take COVID patients out of the clean hospitals, of the usual hospitals. So we have opened army hospitals or hospitals in Congress halls. And we have also opened hotels where to quarantine infected patients with mild symptoms. So if in a family of 5, one of them has symptoms, one of them is positive, we take him out of that family to avoid him infecting other people and put him in a hotel. So there he is alone, he's given food, he's given treatment, we have doctors and nurses there, so he does not infect other people. So now, thanks to this, we have less pressure in the emergency rooms. We don't have, it's still overloaded, yes, but not as much as before. We have less pressure in the ICU, but as I said, it does not mean that we have free beds. No, it just means that we increase the threshold. Now we intubate older people. And there's still a long waiting list to enter in the ICU. So we only admit in the ICU in Madrid when you need to be intubated. And the only patients that are not intubated is when you extube them, and they're going to be 1 day, 2 days without a tube just in case something happens. But usually nobody comes in if he doesn't need to get intubated. And also one major problem that we have in the ICUs is that it's strangling the situation is that patients, these COVID patients require 2 to 3 weeks in ICU ventilated. They're very unstable patients. They're young, healthy adults that desaturate severely in a matter of seconds, and it's complicated to recover. So the ICUs still have a lot of work to do, even though infections and hospital admissions are going down. So what are we trying to do now in Madrid? We'll try to generalize COVID testing. We have done too little. Now we will try to concentrate COVID patients out of the hospital to try to have some hospitals clean of COVID patients so we can assist also other type of diseases that are not COVID. So the question is, if this is happening in a developed country with a good healthcare system, what will happen in a not so developed country with not all these facilities? So the major issue that we are going to see is that we're not going to be able to intubate all people between 35 and 55. It's going to be really complicated. So when healthcare system is minimal, prevention is the cheapest and most practical solution. Do not wait until this explodes. And it's going to be, you're not going to be able to control it. So our resume is this in take this seriously. It is better and cheaper to overreact in the beginning than wait until it explodes. Have logistics ready for when this arrives. Have COVID hospitals ready to avoid infecting existing hospitals. If you have the ability to build a hospital in each region to put their patients before taking them to the hospital, do it. Not make another contaminated hospital. And have protocols in place according to a realistic list of materials and staff that is available. And train people before this chaos arrives. You don't have nurses, or now you have nurses, but you think that if this happens, you're not going to have nurses or doctors. Start calling them, start training them, and say, okay, be ready when I call you, come, but already be trained. And also, if you don't have anything, distance is the trick. Distance, 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 isolate, and self-protection. So that's all for me, and I'm open for all the questions. So thank you very much.
Thank you, Jose. That was great. We will open it up now to questions. If any of you have a question, feel free to ask it.
And I have appreciated numerous questions in the chat capacity of this forum. So please feel free to scroll through as my responses to the questions have been made public.
Yes, hi, it's Monica here. So I've been keeping a list of the questions in the chat function. Bridget, thank you for answering some of those already. Let's give a minute if anyone wants to raise their hand or ask a question now to Jose or Dr. Bridget. Otherwise, I can start reading out some of the questions that have come in and we can start going through those.
I see Innocent Kasima has his hand raised.
Thank you. My name is Innocent Kisima. I work with Assist International in Tanzania. I just wanted to ask Jose one question. In the hospital setting, when to use a face mask and when to use a respirator? Because we have two options. And then there are several procedures that have been done in the ICU. How do you determine this is the right time to wear a face mask and this is the right time to wear a respirator?
You're talking about self-protecting respirator and self-protecting face mask. Yeah. So a normal surgical mask, you must wear always you're in the hospital. Always. That's the minimum. When you get close, when you're going to get in contact, physical contact with a patient, then we put the N95, then we put the FPP2 or FPP3. If you're going to intubate or do anything in the mouth, you should wear an FPP3 if possible. So if you don't have everything, and just put above the N95, put a face mask to avoid more things coming. But always a clinical mask, always a surgical mask. And when you get closer than 2 meters, or you're going to really get close to the patient and do something to the patient, then you put on the other mask. Don't put continuously a more expensive, and we don't have so many FFP2 masks to use it all the time, just when you're getting in contact with the patient.
Thank you so much for your response.
You're welcome.
I see a question from Leonard.
Yes, this is Leonard. I'm logging in from Namibia. Thank you very much for your insights, especially in the lessons learned. Two questions that I have. The first one is, you spoke of about 14% of healthcare workers developing COVID. Was it before the protocol protocols were in place, or even when the protocols were in place, still you were seeing a high number of healthcare workers developing COVID? That's number one. Number two, I'm not sure, maybe you'll be able to answer, or someone who presented earlier. How long was it taking in terms of getting the monitoring, discharging the patient, the swabs becoming negative for COVID using the PCR? Was it usually like within the normal framework we usually read about, like 14 days, or some patients continued to have persistent positive swabs? Thank you.
Yeah, so I'll answer to the first question. So we had a lot of, people starting to, the first nurses and doctors started to get sick after 10 to 14 days of the first patients coming into the hospital. So that's why we know that it was in that situation when they were most exposed. And there were some protocols, but it was like nobody really took it seriously. It's like, okay, let's make like a protocol just in case something happens. We'll put that in the tabloid, but nobody really knew that. And then you could have a protocol of using a PPE, but there was no PPE. You had to go to the pharmacy to get one. So it was not really installed, this situation. So when everything exploded, then we did really a protocol to follow. We had PPE, we know where they are. So now does still exist a risk of infection? Yes. Are we still getting infected? Yes, we are, but in a lesser ratio than before. The problem is now all the hospital is a COVID hospital. So it's everywhere. So it's easier than before to get infected. Before it was especially the emergency room and the ICU. Now it's everywhere. So we got infected since the beginning, but we are still getting infected because COVID is everywhere in the hospital. That's why we want to make COVID hospitals outside of these normal hospitals, to be able to start a normal life in the hospital, assisting also other patients. Just to tell you, most of the patients that we had in the ICU that had a transplant died because of COVID. That did not have COVID, they got infected and they died. The second question, I don't know if you, Dr. Bridget, are able to answer. I'm not sure, I didn't quite get it.
Please correct me if I'm wrong. I believe your second question was asking about the false negative rate of the PCR assay for nasopharyngeal swabs for COVID-19. It has a very high sensitivity. Last studies I've seen are in the 98 to 99% sensitivity. So there'll be more false positives in that scenario than false negatives. However, if you have a very high clinical suspicion on a patient and receive a false negative testing, the recommendation is to repeat that test. I see a question also asking about testing, that should it be done just to know our status? And I think, to reiterate what Jose has mentioned, is we must assume or presume that everyone you come in contact with has COVID-19. Testing availability is globally low, and so we are not able to test everyone just for the confirmation of their status. But by us wearing our face masks and assuming positive viral status, we'll be more adherent and more responsible with our social distancing and interactions with one another.
That's great. It's Monica Kaner here. I'd like to jump in and just ask a few questions that have popped up throughout the chat that we haven't fully addressed yet. Bridget, this one is to you. Do we have asymptomatic patients showing an incubation period up to 42 days And what are the chances of reinfection? And actually that question really could be for both, for either Jose or Bridget.
I saw the question, 42 days is outside of the most studies, what we've seen for an incubation period. However, there could have been an exposure prior to what they initially, while 42 days prior, they could have suspected that was their point of contact. More likely it is they had a more recent exposure. I am currently on COVID-19 home isolation for contact with a confabulating patient who did not share his symptoms so that he was not left out of the hospital. And my symptoms developed 5 days after my exposure to this presumed positive patient. So the 14 days is the most we've seen, but most symptoms are developing within 4 to 6 days of contact. Reinfection has not been a high concern at this time due to our immunological response. When one is infected with COVID-19, you will develop your immunological IgG and IgM antibodies in a non-immunocompromised status, protecting you from reinfection based on the virology of this family of coronavirus. Jose, anything additional?
No, I think everything. Something that we would like all the healthcare staff is be tested to know if we have passed it. Just not only to be calm, it's just who to know who to put in the front line. So if you know some people that already passed it, let them be in the front line and the others take them back so they're a little bit safer. But we don't have enough tests, unfortunately. But that will be ideal. Test everybody. If you pass it, you're okay now, go to the front line.
Jose, there are some questions regarding age. So what is the median age of, I guess, the Spanish population, but also patients in the ICU that you've been seeing?
So what I said, in Spain, we have a very old population. I mean, we live long when the country is not the country that gets to live longest. We're just hand by hand with Japan. It's the sun or what we eat, I don't know. So, so we have a lot of aged people. So what I was saying is that if we had unlimited ICU beds, most of the ICU beds will be occupied by older people. The situation is that we don't have unlimited ICU beds, so unfortunately there's a criteria. Medical criteria is the one that has more chances to survival. I mean, all of them need a ventilator. So if you need a ventilator to be able to survive, then you go to the ICU. So if you have 2 beds available, 8 patients waiting for that, you get the ones that have more probability of surviving. And one of the probability is, I mean, the younger you are, the better. So if you have same type of patient with 55-year-old and same type of patient with 65-year-old, you're going to pick the one of 55-year-old. That's unfortunately, it's war medicine. And usually I see also a question, how much time does it take them to survive, to pass in the ICU? The average we're seeing is 2 to 3 weeks, which is really enormous for an ICU. An ICU normally it's 3 days, 4 days, the average, 6 days, okay? 2 weeks, 1 month, really strange cases, neurotrauma, something like that. But everybody 2 to 3 weeks, I mean, that's incredible. So that's the average. We have people that have been recovered earlier, yes, and some are taking more time, yes, but usually it's 2 to 3 weeks.
And Monica, I see a theme of a few questions asking for healthcare workers and others, how do you know when you can return to work, and or how many negative tests do you need to be considered a recovered patient? So again, as Jose and I have mentioned, the testing availability is limited, even in resource high populations. So the recommendation is to return to work 7 days after your first symptom and 3 days from, you have to have gone 3 days with no symptoms without antipyretics or other medications. You do not need a COVID negative test to be considered recovered, because again, once you're exposed, you will test positive, but that will lead to your own immunity then. And as Jose has mentioned, that actually equips you better to be on the front lines for your own immunological response has mounted to be stronger in the face of caring for COVID patients. Thank you. Sorry, Monica.
No, that's great. Thank you. That was one of the questions I was going to ask. Bridget, another one for you in terms of vaccines. Can an influenza vaccine be a recommendation in making a COVID vaccine? And can we use antibody therapy for patients who have recovered as we wait for vaccines?
Thank you, and great questions. I saw the influenza vaccine question. There is still a role to have patients vaccinated for influenza, but that is a different viral etiology, and it would be treating a different disease process. Currently, one of the vaccines is testing a, I have to peek at my notes. It's testing a messenger RNA that once injected into patients, it allows for a protein spike, and that will elicit your own immunological response. But all vaccines that are candidates right now are still in the testing phase and must be specific to the coronavirus for our immunological response to be matched to the disease that you would have exposure to. And I apologize. What was the second question, Monica?
This was about the antibody therapy from patients who have recovered and using, I guess, convalescent plasma transfusion for passive immunity.
That's right. Thank you. So there have been some studies where a patient, for instance, if I have proven to have been exposed and have now converted to being COVID positive, in a non-immunocompromised situation, my immunological response will mount natural antibodies. Plasma from previously infected patients like myself, now recovered, have been tested to be given to test subjects not yet infected to see if there are some passive immunity benefits. We are seeing some benefits, but there is still testing as to how long is the protective immunity and how efficient, how strong of a protection is it providing. So it's still early in the testing stages. And I think it's important to mention there are other risk factors with plasma transfusion, especially in under-resourced countries. So we need to be careful with hepatitis or HIV transmission, which would complicate the situation and not lead to patient benefit. So this plasma transfusion should be a last resort in many of our situations here today.
That's great. Thank you. For Jose, can you talk a little bit about triaging? I think people are very curious, particularly across Africa, how triaging can be done, in weaker health systems.
Okay, so the best recommendation is to have a special place to do triage out of the hospital. So you have the possibility of having tents like we're building outside. So before anybody goes in the hospital, do a triage. So you have a doctor with a PPE, nurses with PPE, then you do the triage if you think it's COVID. If it's possible to take them in a part, you can separate COVID patients from non-COVID patients, that would be the best. But try to do that triage always before you enter the hospital. That's what we're starting doing 1 month late. We should have done this before. Now, triage should be done outside of the hospital. And everybody that gets in contact with triage, you must think he is positive, always. FFP2, N95, complete PPE, you evaluate that patient, and then you do the triage out of the hospital if possible. That's what the Army is doing. That's what we are all doing now. I don't know if I can say much more about that.
Thank you, Jose. Are there any other questions that people might have?
Okay, we do have some others by chat. We just wanted to see if anyone had any live questions they wanted to ask. One interesting one is why, and I'll pose to both of you, is why more men are affected than women.
Yeah, that's not good for me. Yeah. Well, when I entered the ICU, I'm 42 years old, I'm a man, and I have overweight. So when I entered, 90% of the patients were men above 35-year-old and with overweight. So yeah, I don't know why, but it's like that. And we will know maybe later, I don't know why is it, but yeah, it's true. And what is true is that overweight is one of the situations, probably because having overweight, it gets it's more difficult to breathe. You have this big amount of weight pressing the lungs. So when you get it's as a nurse, you like when a patient doesn't have overweight because it's easy to ventilate, much more stable. You have an obese patient, to ventilate him with a ventilator, it gets much more aggressive. You have much more probability of damaging the lungs with the pressure, the excessive pressure. So yeah, it's happening. That's what we are seeing, but we still don't know why. That's our problem.
I do know, as Jose referenced, there is a suspicion that the higher level of comorbidities are in men, especially cardiovascular disease. So that could be skewing some of our epidemiology with more men presenting than women, as unfortunately my male cohort recognized.
Great. I'm going to ask a few questions that we received in the pre-questions in the registration, which were really great. And then maybe if we have some time, come back to the ones we're receiving now. This came up on our call last night as well. But what are the important aspects of medical waste management and how to deal with that because of COVID? And what is the effectiveness of a disinfectant box or a tunnel at the entrance of a hospital or building?
Well, regarding for the waste, you must have clear where is the clean path, where is the dirty path. So we just put, for example, in the wards, in the ICUs, we have put like tape on the floor, so 2 meters from the bed. So we have buckets inside for the waste. So you take that bucket out, then you open a clean one from outside and you put it from inside without touching anything around in another bag. So you should use a double bag or triple bag, depends, to take that out. So that anybody that is going to touch afterward that waste bag is not going to have the possibility of getting infected. So it's a dirty part, and everything that goes out of there, even you, have to be cleaned before going out. I mean, even the patient that passed away, we put a double, I don't know how to call it, this sheet for the dead people. We clean it with bleach, him, the patient, and we put a double one, and each one, we clean it with bleach. Each of the bags, we clean it with bleach, and it has to go out infected. Everything that goes out of there must be disinfected. And what was the second question? I think, yeah, the tunnel. So we did that experiment in the tunnel in one of the army, hospitals, but it didn't last long, because to have one of those disinfection tunnels really cool with a spray liquid and everything, you need to have really good PPE. You cannot spray a normal mask with that. So, also the problem is that you don't put the PPE and everything on when you enter the hospital. I mean, you're staying 12 hours in the hospital. You usually put a normal hospital dressing, and when you go to the area infected, it's when you gear up. And when you go out of there, you take out that PPE. You're not with the PPE around everywhere. That's what we are doing. So you will need to have one of those tunnels in front of each ICUs and each ward and each emergency room, which is not really practical. So finally, we decided not to do that. Maybe in an army hospital more developed with a perfect PP3 always, and you just go in for 2 hours, then you go out, you could do that. But we're seeing that it's not being practical for us. What we do is every time you go out, someone has to look at you and see that you're taking out everything correctly. And it's helping you to disinfect yourself. So with that, we're seeing that it's enough for now. So I would say that it will be a very good idea for Ebola, but for this, as we're doing it, it works fine how we're doing that.
Thanks, Jose. We have another question from Leonard, and I think it's particularly relevant to a lot of the people on here. Leonard?
Yes, so in Namibia, we currently have about 16 patients confirmed, but the first 2 of our cases, they're both mild. It's around day 16 now, and they're still positive on the PCR. So we were just wondering, any experience on how long some of your patients are taking during monitoring to get to negative? And then the second question is on any experience on use of hydroxychloroquine. We've heard a lot about it. Were you using it, or are you using it in Spain? Thank you.
I'll address the second question first. I might need clarification on the first question. There was also a question about this in the chat box from Abigail. So yes, there are some agents being used. I would say they're all under investigation, and there are clinical trials for the use of agents with serious or critical disease. I have an 81-year-old patient currently intubated with advanced SARS disease from COVID-19. She was first given remdesivir. It's a nucleotide analog given intravenously, and she had no response to that agent. But now she's receiving hydroxychloroquine, and there has been some initial studies on both of these agents that look promising. I think the importance with hydrochloroquine and chloroquine are, and with any agent that we use, is to be very familiar with the potential for toxicity specific to those anti-malarial agents. There's the risk of QT interval prolongation. So no patient should be given these agents without medical care and surveillance. It should not be given prophylactically. It should be used, again, for the smaller percentage of patients that have serious or critical disease, and these would be those patients in a hospital setting. And the dosing for these agents differs, but you can find recommendations for dosing in the CDC or WHO websites. And Jose, if you heard the second question, I'll defer to you, or I might need to hear that one again. I'm sorry, the first question.
Yeah, could you repeat the second question, because I forgot after listening to this. By the way, in our ICU, we are using hydroxychloroquine. Not all are using them, but we are. So could you repeat the second question?
Yes, I'll do. So we have a couple who have were confirmed COVID about 16 days ago. So now their symptoms have resolved. They're basically fine, asymptomatic. But as we are monitoring, because in our guidelines we need to do another nasopharyngeal swab again, and it has to be negative over 24 hours so that we can discharge them. But even though we are at day 16, they still have a positive nasopharyngeal test result. So we just wanted to find out from your experience, how long are some of your patients taking to get to negative as you are monitoring them?
Usually when you don't have symptoms, I mean, as the doctor said, a few days or some days after not having symptoms should be negative. But we have found cases, for example, we have a politician, I mean, one of our vice presidents in Spain with very mild symptoms was positive. Then no symptoms for 1 week was negative, and the week after was positive again. So this could happen. That's not the normal thing. Usually it should be negative. We don't know if the second negative was really negative or it was positive or a false negative. So that's also what we did. I don't know, Dr. Bridget, if you can add something about how much time it takes to be cured, if you need another negative, from how long after the second negative.
So so I know our current CDC testing is a PCR assay, and so I'm unfamiliar with how long that would take to have like you're speaking of a false negative, for it to be a true negative. It's important to recognize serology testing, which is antibody based, would not turn negative. That you would always have the evidence of former infection with your IgG there. But I'm not sure how long it would take. I think also with the limited availability, I don't think it's a advised management to test for negativity, because right now the testing is so limited. We need to save the quantity we have. So instead of focusing on a negative test, we could isolate and prevent direct transmission, and then re-enter based on symptomology of the patient having not be there any longer. I think that's just a global opportunity that's a little more realistic.
Hi, it's Monica here. I wanted to ask a question about personal protective equipment and what can be done when there is a lack of PPE, and or if there's a need to potentially reuse PPE. What are your recommendations?
We are, I mean, in Madrid, the thing is we've had lack of PPEs sometimes. So we have done PPEs. Let's call it PPE, but it's not a PPE really, with plastic bags. So we have the thicker the better, plastic bags. You do a hole for the head, you do a hole for your arms, and then you have a PPE. We have that issue sometimes. It's not normal, but we have it. And it's true that some PPEs can be decontaminated. Those that are complete, like like a complete suit, legs and everything, our hospital has said that we can decontaminate them. So they are decontaminated and we use it once again. So we use it twice. There's another one that is really thick that can be used several times. So before throwing that away, be sure, test if you could decontaminate it, because we found out this late and now we are recovering them. So when you use it, you mark it if you use it. So one type, we use it another day, so it goes down to decontamination, then you use it again and then it throws away. And others can still be used 3 or 4 times, which is a really thick PP3 device, a gown. So it depends, but you should think of that before this happens. So you have that, try and think of it. Or plastic bags that we have used. I mean, the bigger the better, plastic bags. That covers you the most. And how to do it. We have, you can see in YouTube tutorial trainings of ICU nurses how to do a PPE with plastic bags. Yeah.
I see your question, Charles Masembe, asking about the potential differences geographically as well as phenotypically with Africa to Asia, and I think you're asking, with the distance, have there been mutations or findings that explains the lower death rate? Correct me if I'm understanding your question incorrectly, please, but I think there are definite age differences when you compare an African versus Asian population that could have affected the death fatality rate, comparing those populations. And then just lessons learned when you're the first population to be exposed to, at the time, an epidemic now has become pandemic. These second and third waves of countries affected, we're learning from those ahead of us, and that can help us with truncating the disease process prior to fatalities and deaths. I hope that, Charles, please correct me and let me know if that answers your question.
I do want to be cognizant of time. I have a few final questions just to ask, I think that are relevant to this particular call. What is the role of antiretroviral therapy in the management of COVID-19 cases, or is there any evidence on that right now?
There's studies of different agents, but the traditional HIV antiretrovirals so far have not been proven to be efficacious. Again, there's lots of testing still underway, but none that have yet proven to be worth the side effects and comorbidities of antiretrovirals, traditional antiretrovirals.
Thank you. And one final question to both Dr. Bridget and Jose. It's kind of a two-parter, but just what do you see as the most pressing need for Africa right now in terms of COVID-19 response, and how they can set, how the countries can best set priorities to help prevent and treat?
From my side, I'd say if you could get tests, the better. And as soon as you have someone that is positive or suspiciously positive, find out who that person has been in contact with and isolate them too. That's something we did not do in Spain, and in Korea it worked very well. So you don't have resources, try to isolate as soon as possible, and study what happened before that positive, because that patient may have been infecting people for 1 week. So what happened the day before with this person? Where was he? And isolate also those people. That's what Korea did, and it worked very well for them.
I agree. I think having lived in Eastern Africa, I saw a question of, how do we notify our remote village population members of changes, and really we have radios or mobile money, texts, and messaging, phone messaging that we can rely on for transmission of important information, and newspapers. But I think the key is the social distancing. So the remote villages and the home isolation to your hut and your family is imperative at this time. And then if symptoms develop and you're in the 81% of patients with mild disease, I think it is imperative that you stay home, you shield yourself from other family members as best as possible, and you continue to use important and regular hand hygiene.
Thank you. Okay, thank you to both of you. I'm cognizant that it is 9:30 a.m. Eastern, and we have run out of time. I will pass it along to Chase in a second to close out, but I do want to mention we will be uploading our presentations and hopefully other resources as soon as possible on our assistinternational.org website. And if you have pressing, we will be sending out a follow-up email. So if you have pressing questions that weren't addressed here, please send them to us and we will get them over to Jose and Dr. Bridget. And hopefully we can continue the conversation. Lastly, I will mention this is going to be a weekly lecture series. It is still evolving as the situation is still evolving, but we will be covering quite a number of topics. Early diagnosis and triage, we did some of that already. Airway management considerations, oxygen therapy, acute cardiac injury and arrhythmia, management of cardiac injury, pediatric patients, severe sepsis and shock, as well as many others. So please keep joining us weekly. We will send out an invitation for next week's session within the coming days. Chase, over to you.
Thanks, Monica. Thank you, Dr. Bridget and Jose, for your presentations. They were excellent. Thank you to Charles for providing translation for us. And as Monica mentioned, we'll be sending out invitations shortly for the next sessions, as well as links to the video of this recording, as well as the other presentation material as well. So thank you, everybody, and we hope to see you next week.
Thank you.
Thank you.